Morning to you, ladies and gentlemen. This is OP Yadav, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery and CEO, National Heart Institute in Delhi. And it's my proud privilege to play host to Dr. V.V. Bashi, a very renowned aortic surgeon from this country who is based in Chennai, India. Welcome, Bashi.
Thank you.
Bashi, you are one of the leaders in the field of aortic surgery in this country, and with vast experience in aortic dissection. What are the main problems in correctly diagnosing the disease and the extent of the disease?
The first problem is, because of the presentation of this with the pain, sometimes it may be misdiagnosed with myocardial infarction, acute myocardial infarction.
Sure.
But today, with the availability of CT scan machines almost in every part of our country, most of them are diagnosed within 24 or 48 hours.
Okay.
And once you do a CT scan, they are being referred to the nearest place where it is being done. So you have to have a good diagnostic radiologist who can assess the aorta at 0.5 millimeter thickness, because that's very important to manage this patient with aortic dissection, because the information given from the CT is the most important thing.
Is it important to know the details of the entry points, primary and secondary?
Very important, because that is very important to plan the exact management of the patient. Today, because the aortic dissection, the surgical management is standardized almost all over the world with the evidence based, it is very important to find out the primary tear location.
Okay. Now, coming to a little bit of technical aspects, what factors play into your mind when you are deciding on the cannulation technique for these patients?
Cannulation techniques depends upon how the patient present to you. For example, there are so many cannulation techniques available: axillary artery, femoral artery, direct aortic cannulation, then carotid artery I have already mentioned. So these are the usual areas where we cannulate. If the patient is really sick, the easiest way is to cannulate the femoral artery.
Okay.
You can straight away get on to bypass, but one of the problems is, there can be malperfusion problems. Otherwise, the median stenotomy and direct cannulation with the Seldinger technique is the best technique actually.
Okay.
But if the patient is stable, axillary artery or carotid cannulation can be done.
Okay. Now, you mentioned about malperfusion. That's my next question. How do you handle malperfusion in these cases?
Yeah, malperfusion depends upon where the dissection has gone and produced ischemia. It could be, start with coronary itself, patients can have infarction or ischemia, then carotid or innominate arch vessel perfusion coming with stroke or impending stroke, sometimes paraplegia, visceral malperfusion and peripheral malperfusion. Today, except for visceral malperfusion, if a patient presents with a type A dissection, treatment is do the primary treatment, that is correct the dissection, type A dissection, you correct it, and if the patient does not improve, like neurologically, or the renal function does not improve, or the visceral does not improve, or the peripheral does not improve, only secondary intervention. Whereas when a patient coming with visceral malperfusion, the mortality of that patient is almost as high as 50%. Patient will have acidosis, they will be very sick. So if you do a primary correction in that patient, the mortality is very high. So in these cases, you manage the patient conservatively first, try to do a intervention or sometimes open surgery to correct the visceral malperfusion, and then correct the electrolyte imbalance, and then take the patient to the theatre and do the primary operation.
How about the distal arch? If the arch is involved, how do you handle that
in
type A aortic dissection?
Yeah, arch involvement is a very difficult problem to tackle. Patient will be more sick, and the mortality in this case is slightly higher compared to isolated ascending aortic involvement. So as a rule, of course, we diagnose these patients by CT, whether there is tear in the arch or distal to that. So we plan the operation before itself. So for example, if the arch is involved, you have to definitely have a circulatory arrest and open the arch and do a proximal arch replacement and a root, or where facilities are available and the surgeon is experienced, the best treatment is a frozen elephant trunk arch along with the arch replacement. So the distal aorta is
So what
tackled.
percentage, I mean, are we doing frozen elephant trunk in this country?
Yeah, acute dissection, not, I have done maybe 3 or 4 cases only,
Okay.
frozen elephant trunk, because it takes more time in a sick patient. Plus, we don't have the frozen elephant trunk graft ready-made available in our country. It is not available. So we are doing a modification with the existing graft and connecting into a plexus graft and repair.
So hybrid kind of.
Hybrid kind of thing.
And the last thing I would like to know, how do you handle the aortic valve? I mean, decision for conserving it or replacing it?
Yeah, it's a very pertinent question, because you know, if the surgeon is experienced in doing in a good number of aortic root, definitely he will try to conserve the valve if it is possible.
Okay.
Conservation. That depends upon other factors also. Suppose the aortic leaflets are healthy, aortic sinuses are not dilated, and young patient, the results will be very good. Whereas if the sinuses are dilated and the diameter of the aorta is big to start with, and the leaflets are not good, definitely one would go for a root replacement. And of course, root replacement is not a bad operation in experienced hands, and also in people who are not that experienced in doing repair, it has got a good result early as well as long term. So wherever possible, you should conserve the aortic valve, especially in an young patient.
So ladies and gentlemen, we just heard Dr. Bashi. He mentioned about the problems of diagnosing, especially the extent of the disease. We just talked of the cannulation techniques as well as the decision making involved in either conserving or replacing the aortic valve and how we handle the distal arch. Well, thanks, Dr. Bashi,
Thank you
for
very
sharing
much.
your thoughts with us.
Thanks a lot.
Thanks for coming.
Thank you.
Thank you. Dr. Bashi, what percentage of these patients where do you do a type A aortic dissection standard repair, do they continue to have false lumen distally as patent, and how do they dilate or not? And what is your follow-up protocol?
Most of this patient who comes with the distal dissection will have a problem in the distal aorta on follow-up if it is not tackled at the first time.
Okay.
So it's very important to follow them up, especially in a young patient and patients with Marfan syndrome, where the aorta continue to dilate at a faster pace other than in a other type of diseases. So it is important to screen them. Usually we screen them first CT aortogram you do after 3 months, then we do it every year and see if the size of the aorta is increasing. If the size increases more than 1 centimeter a year, or if it is more than 5.5 centimeters, the distal aorta, it is an indication for intervention.
Okay. Thanks a lot, Dr. Bashi. So this is it's over. Thanks. Yeah.